started. So welcome everyone to the CMR Journal Club of March 5th. My name is Nicole Seiberlich and I am a PhD physicist at the University of Michigan, and I'm delighted to welcome you all to the meeting today. So our theme today is looking at radiomics and how that affects the images that we are collecting, how we can process them, and how we can extract additional information from those images. So we have two great papers for you today, and we are going to start with a paper that will be presented by Dr. Manzke and Dr. Meinel, which is entitled Repeatability of Radiomic Features in Myocardial T1 and T2 Mapping. So at this point, I'm going to ask them to share their screen and take it from here.
Sure. And you should be seeing my screen now.
Yes. Yep.
Perfect. Well, first of all, thank you so much for reaching out to us and to inviting us to present our work and discuss this paper with you. So I just want to start by quickly explaining why we did this study. We saw a number of papers coming out over the past couple of years, and we referenced some of them here in our introduction, that have looked at radiomics features as tools to diagnose a variety of cardiac conditions, cardiomyopathies, but also myocarditis, or to use them as prognostic biomarkers to predict the clinical course of these patients. So basically, our rationale was to think, well, wait a minute, shouldn't we first make sure that these features are actually reproducible? Because if they are supposed to be valid biomarkers to diagnose or make prognostic implications, then they should at least be repeatable, at least when we repeat the same scan under identical conditions. So that's really the main point of the study, was to look at the repeatability of radiomic features in myocardial T1 and T2 mapping using a cohort of individuals who were scanned with two identical CMR scans on the same day. And we were also interested to see if the slice orientation, so using short axis versus long axis mapping and the spatial resolution, would have an effect on this reproducibility. And with that, I want to hand over to the first author of this paper, Mathias, who will present you the methods and results in more detail.
Yes, thank you very much for the kind introduction. My name is Mathias Manzke, and I'm a data scientist here in Rostock. So that's what we did. Yes, we have a cohort of 50 healthy volunteers who underwent two identical CMRI examinations. Yes, we have 29 women and 21 men with a mean age of 39 years without cardiovascular diseases. Yes, the examinations were performed at the same day between a break of 20 minutes, and we used a 1.5 Tesla MRI scanner from Siemens. And the protocol includes T1 and T2 mapping, as well as short and long axis orientations with two different spatial in-plane resolutions, 1.9 cross 1.9 square millimeter. For the standard resolution, we used as clinical standard, and 1.4 cross 1.4 square millimeter, the higher resolution. Yes, then we applied radiomic features, radiomics on the segmentation, which was manually segmented by a clinical physician. And yes, we analyzed 100 radiomic features from 7 feature classes, as you can see here. And afterwards, we determined the robustness of these features using the ICC, intra-class correlation coefficient, as primary parameter, and the concordance correlation coefficient and the Pearson correlation coefficient as secondary parameters. And then we classified the robustness with a 4-point scale from poor to excellent, as you can see here, according to the definition of Kuh and Lee. Yes, and then we go over to the results. First, we divided our analysis into 4 quadrants. Divided for all combinations, first for the T1 mapping images, for all combinations of standard resolution and short axis, standard resolution and 4-chamber view, high resolution short axis, and high resolution 4-chamber view. And what you can see here is that we have overall classes high variability, so not so much radiomics features were very good or excellent. And that's why we did further analysis. Let me see here. That's the more detailed results of our analysis. The features and the feature classes here in bold are those features that performed at least good for all combinations of resolutions and orientations, so that we identified 15 radiomics features from 7 feature classes with good or excellent robustness. And the same we did for the T2 mapping. First, we divided it into the combination. It means for T2 mapping we only analyzed, we only collected the standard resolution. We don't have high resolution for that, so that we have only 2 columns of results here, but we analyzed it in the same way. So, and in more detail, we found 12 radiomics features from 5 feature classes that performed good or excellent. So yes, that was the methods and the results, and I will go over to Felix.
Yeah, I just want to wrap it up and say that there are some important limitations that we should mention of our study. This was only healthy volunteers, so no pathologies included in this cohort. This was only 1.5 Tesla data from one specific manufacturer. So what we looked at really was repeatability under identical scanning conditions. So so obviously robustness will be probably even more limited if we're looking at cross-vendor or cross-sequence reproducibility. And only native T1, no contrast, was given to these volunteers. So I just want to wrap it up and say I think the main point of this study is just to raise awareness that only a small number of radiomic features are reproducible in myocardial T1 and T2 mapping. So I think the takeaway point from our study should be, if you're a researcher and you're planning a cardiac MRI study involving radiomics research on mapping data, then just be aware of this issue of reproducibility and make sure that you're selecting features that have shown to be reproducible. Thank you very much for your interest, and we're looking forward to discussing this with you.
Thank you very much.
All right, thank you so much for that wonderful explanation of this paper. To our audience, please feel free to either raise your hand or drop a question in the chat. There's already a couple of questions, so I'm going to start by reading the first one. Actually, there's two questions. Number one, why were only 100 features chosen out of the available 1,034? And two, how was the quality of the maps assessed? And were the mapping values reproducible in these maps? Let's start with number one. Why just 100 features?
So thank you very much for these questions. First of all, the first part of the questions, why only these features? Well, the ones that we didn't look at are the wavelet features, I think, because this would have increased the number of features as so much. Because really, in contrast to other publications on this topic, we were interested to really look at specific features and their performance, rather than just report, the performance of classes of features. And to do that, we really had to focus on a set of features, and we decided to exclude wavelet features because that was beyond the scope here. And sorry, the second part was...
The second question was about the quality of the maps. So were the maps themselves reproducible, like the values that you measured for T1 and T2?
And that's a great question. And I think this is this goes back to another analysis of this data, which was published in a separate paper where we looked at regional differences in the reproducibility of mean T1 and T2 mappings. And that was a paper that we published, I think 3 years ago. Benjamin Böttcher was the first author on that paper. And from the same cohort of a cohort study, where we looked at the regional reproducibility and found that there are indeed regional differences between the reproducibility of the mean T1 and T2. But this paper basically focused only on the reproducibility of radiomic features.
Got it. We have another question. So the commenter says, great paper. I'm a little surprised that there was any difference in reproducibility of the shape features between T1 and T2 maps, given that these features are more dependent on the segmentation rather than on the gray values or parameters themselves. Any idea why this might be?
Yes, I guess we discussed it already in the paper. Yes, we think it depends on the U shape of the long axis we use. Yes, yes, the short axis views are more circular. So, and I guess that could be the reason why it differs a little bit over the entire data set. But we not quite sure if that is a good explanation for the question. So.
Well, maybe I can add that. I mean, I agree that it's a little bit surprising, and we did see, if you look at this figure, that the 2D shape features are in general quite reproducible, more so than other feature classes. But I would also agree that it's surprising that, I mean, 2D shape features are mostly about the shape of the segmentation, not so much about the mapping data themselves. So it's surprising and interesting that we even saw that some of these features are not reproducible, even though we had the same person segment those maps in both scans. So it was not a question of inter-rater variability, but rather the same person. I mean, it was two different scans, Maybe it was positioning of the patient inside the scanner, because the individual was taken out of the scanner and put back in. Maybe this positioning of the slice or of the patient was slightly different, or the segmentation was slightly different. And even these slight differences already led to poorly reproducible features even in this class. So I think that's interesting.
All right, I have one last comment, even though we're running, or question, even though we're running out of time. Can you comment on the features that have been suggested to be used for clinical assessment? Like, are the features in here, do they kind of cover that umbrella of features which have been suggested, and are those features reproducible, or do we need to kind of go back and revisit some of those publications?
Yeah, that's an excellent question, and I think we actually that's one of the reviewers when we were publishing this paper asked the same question. I think we tried to address this a little bit in our discussion. For example, I want to make this short. I know we are running out of time. Just to give you an example. So basically, so for example, we're discussing some papers here that, for example, for myocarditis, they use a combination of two radiomic features and show that the combination of those two is optimal to diagnose myocarditis. This is the paper by Bettina Bessler. And in our cohort, one of those features was highly reproducible, whereas the other was extremely poor. So, and the same for other papers that we discuss here. So it really, so the short answer is some features are reproducible that have been suggested as biomarkers, and some are not in our cohort.
Perfect. Okay. With that, I want to thank you guys again for this wonderful presentation. And we are going to switch to our second publication, which is going to be presented by Dr. Yamlome and Dr. Jordan. And this paper is entitled Effect of Magnetic Field Strength and Segmentation Variability on the Reproducibility and Repeatability of Radiomic Texture Features in Cardiovascular Magnetic Resonance Parametric Mapping. So you guys can go ahead and share your screen, and we're eager to see what your paper has to say too.
Thank you, Pascal. If you want to pull up the paper. For brevity's sake, I'll just cut our introduction a little bit shorter here. Thank you for the opportunity to present our work here. Pascal is a PhD candidate in my lab, and one of the questions that we had as we were looking at the paper similar to the last group is, there's increasing publications in radiomics, but what do we know about the reliability of these features? And we were also motivated to look at segmentation as well as the field strength with an eye towards the future of potentially combining multi-center databases on T1 mapping and different disease models. So I'll pass it over to Pascal now.
Thank you, Dr. Jordan. So I'll go straight to our aims. All right, so we had two main aims for these studies. One was to assess the effects of segmentation variability on the repeatability of radiomic texture features, myocardial radiomic texture features. And then secondly, to ascertain the reproducibility of RTS across scanners from different magnetic field strengths. In this case, 1.5 Tesla and 3 Tesla scanners. And this was a retrospective analysis performed on 45 paired CMR scans acquired from 15 healthy volunteers. This is an overview of the study pipeline. I'll quickly go through and then give more details on some portions. So 15 healthy volunteers were scanned on a 1.5 Tesla cement scanner and a 3 Tesla scanner within the same hour. For each one of them, we acquired 3 short axis T1 maps of the LV myocardium. And then, the scans were acquired at the base, mid, and apex. And then each scan was manually segmented or automatically segmented. We'll look at the automatic segmentation part in more details. But the segmentation was done in 3 independent segmentation runs, and for us to be able to like compare how like changes in the mask that is captured affects the repeatability of the features. And for each image mask pair, we pre-process with one of these filters, and after that, a set of 93 features were extracted. Essentially, these filters can be grouped into 2 main categories, at least depending on how we look at them, right? So we can talk about filters that transform the image based on point operation. So they transform single pixel values. So examples are the square root, the square, the logarithm, the exponential. And then filters that process pixels based on that pixel and surrounding pixels. Examples are the gradient, the LBP 2D, and the wavelet filters. So after pre-processing and extracting features, we have 1023 features extracted from each image mask pair, right? So for these features, we can compare features extracted from 1.5 Tesla images to features extracted from 3 Tesla images for reproducibility. And then we can compare features from segmentation run 1 against run 2 and 3 for repeatability, right? So since one of our aims was to study the effect of segmentation variability, we needed to find a way to measure segmentation variability itself. So we came up with a simple method, a simple and interpretable way of doing that. And here we extended the idea of intersection over union to account for multiple segmentation masks. Essentially, we take 3 segmentation masks and then quantify the proportion of pixels that were in agreement in all those 3 masks. And then for any 2 masks, that's IOU2, and then the proportion of pixels that were not agreed upon by any of those 3 segmentation masks. A good property here is that these values always range between 0 and 1, with 1 meaning that, so for IOU 3 equals 1, for instance, means that there's a complete overlap between all the 3 masks, and then they always sum up to 1. Right. So now that we have this easily interpretable way of quantifying segmentation variability, the way that we actually simulated segmentation variability was through an in-house deep neural network that was like designed for image segmentation, a UNet. The idea here is that we leverage Monte Carlo dropout, which is originally used for regularization in neural networks. So what we tried to do was that each time during inference, we drop some weight in the network, right? So this gives us the chance to use a slightly different version of the network each time we are performing inference. And so we use dropout probabilities ranging from 0 to 0.3 thereabouts in increments of 0.2. And each time we sample with a given dropout probability, the network is able to generate a slightly different mask from the previous generation using the same dropout probability. And the variance in this mask increases as dropout probability increases. So having all that in mind, we use the same metric or the same index to assess reliability. So we defined repeatability as the extent to which, let me start from reproducibility first. Well, I mean, we define repeatability as the extent to which multiple measures of RTF that are acquired under identical conditions. So the same the same patient, same scanner. The only difference here is differences in segmentation variability, right? So the extent to which these features agree with each other. And this was measured using ICC 2.1. And then reproducibility, we define that as the extent to which features that are extracted from different scanners, so 1.5 Tesla and 3 Tesla scanners are consistent with each other. So let's quickly go through the results. So we look, so across field strengths, that's 1.5 Tesla features versus 3 Tesla features. We realized that none of the features had excellent reproducibility, right? And for features, we had only about 7% of the features having good reproducibility, and then 40% and 50% respectively had moderate and poor reproducibility. Now, when we group these features according to their filter classes and sorted them by the proportion of features with good or better reproducibility, we realized that the top half of this list was dominated by the neighborhood-based operation filters, right? Which means that filters that extract or transform the image based on a regions were less susceptible to these variations in image acquisition parameters and represent tissue characteristics more intrinsically. For the manually segmented scans from round 1, 2, and 3, when we compared them for repeatability, we realized that roughly a third of them had excellent repeatability. About 40% had good repeatability in the 1.5 Tesla images, and similar results were also obtained in the 3 Tesla images as well. Now, coming back to the effect of segmentation variability. We have this mask here to help us to interpret our intersection over union metric, right? So here we show 3 masks that are overlaid on each other, right? And the extent of overlap between the 3 masks so the yellow region here is the area that is agreed on by all the 3 segmentation runs. And that for this mask, the IOU 3 value is somewhere around 0.78, right? So with this as a reference, this is the proportion of pixels that were captured in the whole, like segmenting the scans for the whole data set that achieved congruence, right? So we had about 72% of the pixels captured by all segmentation runs were common to round 1, 2, and 3, right? So now that we know how to interpret this metric, let's see how we use that to assess the effect of segmentation variability. So here, these bars show the IOU values for each dropout probability. And dropout probability of 0 means that we did not drop any nodes in the network that we use to segment the mask, right? So obviously you expect the same mask to be produced each time you run inference to generate a mask. And that number, so the IOU 3 value, you could see that decreased as the dropout probability increases. And with that decrease came a decrease in the number of, or the proportion of RTFs that had excellent repeatability, here showing us, and you can see how the manually segmented scans stack up against the automatically segmented ones, right? Here you can see the room that we have for improvement, right? The gain that we can make in repeatability of radiomic Tesla features if we are able to segment masks more consistently. So in a nutshell, we just sought to compare the effects of segmentation variability and differences in magnetic field strength on the reproducibility of radiomic Tesla features, and we identify that there are subsets of filters that produce features that are more faithful to tissue characteristics and less resistant to these changes. The findings of this study are particularly important in feature selection pipelines, right? We envision this helping by simplifying like feature extraction pipelines, right? So instead of going and extracting all features, you can just focus on the reliable features. We also want to acknowledge a number of limitations that this study comes with, the fact that this was performed in a small cohort and using single vendor scanners as well. Thank you.
Great, thank you so much for presenting this really interesting paper. Just one question from my side, just so I understand, because I might have missed this. When you were looking at the repeatability at like one field strength, you were looking at how repeatable the radiomic feature was on different segmentations, but did you, or in a test-retest scenario, like with 2 scans of the same person?
So repeatability, so the same scan but segmented different times.
Got it. Okay, that's really interesting then, that even if it's exactly the same scan, that so many of the features are, still not quite great. Because you think with exactly the same scan, just like a small difference in segmentation, you'd hope that it wouldn't cause a huge difference. But it's interesting that even within the same scan, you're seeing issues with some of the features, which I think is super interesting.
This is where automated segmentation methods may help improve the percentage there that we get.
But like just to add like this repeatability, with segmentation to, what was found in the previous paper, where if you have 2 different scans of exactly the same person at almost exactly the same time, that the features, the number of features which are reproducible also drops. So you have to kind of like put both of those things together, which I think is a huge challenge, but I'm glad that you guys are looking at it because I think it's really important. We do have a question in the chat, and if anyone else has a question, you can drop one in. So the comment is, thank you for this very valuable contribution. Were the feature extraction settings identical for 1.5 and 3T, or did you adjust bin width, for instance, to account for the different ranges of values that you would expect? I wonder if this would impact a comparison between the field strengths.
Yeah, so we resampled all the images to an in-plane resolution of 1 millimeter by 1 millimeter or so for all the images before extracting features. So yes, the feature extraction parameters were the same.
So I think, just to make sure I'm understanding the answer to, I think the question is about like just the actual values, that the T1 values at 3T are going to be fundamentally different than the values at 1.5T. So did you have to kind of think about how that would change what, like, what the values of the features might be?
Can you come again?
So I think the question was less about resolution, but more about the fact that T1 values are much higher at 3T than at 1.5T. And so you might want to kind of calculate the features in a slightly different way in order to make them more comparable. I think that was the question.
We did not make any adjustments for that, right? I mean, the goal was to like naively explore like the features and see which ones are reproducible and which ones are not. So we didn't do like any transformations to like get them to be on the same level for extracting.
Okay, got it. You're getting a little quiet, at least on my end. So for the next question, I'll ask you. It's all good. We can still hear. So a question from Matthias, which is reproducibility mainly affected at the border zones of the contours, which seems to make sense. If so, would adding an offset, so like reducing, kind of eroding those segmentations and reducing pixels that contain blood and myocardium help? Or I guess just reducing the ones that contain blood pool.
Yeah, this is a great question. I mean, certainly in the commercial softwares, there is the ability to increase that offset to 10% or so. That is definitely where we saw the most effects were on the border zones. So again, standardizing the analysis, trying to keep an offset or an automated analysis should hopefully improve the repeatability that we see in some of these radiomic features. Thank you.
Awesome. There's just one comment which we'll wrap up on, which is the oncology radiomics research community has had to address the scanner field strength reproducibility issue, if that helps at all. There's a link now in the chat if anybody's interested, so you can grab it there. With that, we're a little bit over time, but I think it was worth it because these were two really fantastic papers which kind of help us, keep in mind some of the limitations that we might have when working with radiomics, which I think is essential when it comes to making these techniques actually applicable in clinical practice. So I really appreciate these publications and their authors for joining us. And I'm just going to briefly hand over to Matthias, to present the Journal Club for next month.
Yeah, thank you very much, everybody, for attending and for the presenters for the very interesting papers. Just a quick announcement of next month's CMR Journal Club. It will happen on April 2nd, and it will be a featured paper on a topic that I find is really a little bit still underrepresented. It's CMR in hemorrhagic infarction. And there's some very interesting new data from Rohan Dharma Kumar's group, and so they were recently published in JACC Imaging, and they will also discuss an editorial that is associated with that and another paper by the same group. Thank you very much, and look forward to seeing you then on April 2nd.